So we're good to start.
Hi, good evening. Welcome to webinars organized by Yashoda Hospitals, Hyderabad. So today I'm Dr. Vinith Ilapuram. I am Head of Department Emergency Medicine, Yashoda Hospital, Secunderabad branch. Today we are here to discuss on pediatric trauma. So we are having a speaker, Dr. Shefali Sharma. She is head of the department emergency medicine as well as assistant director for Tender Palm Superspeciality Hospitals, Lucknow. She is as well as trained NABH internal assessor, and she has more than 10 years experience in emergency medicine. So over to you, Dr. Shefali. You can go ahead start.
Thank you, Dr. Vinith. I'll just share my screen once.
Yeah.
Yeah. So is it visible? The screen is visible?
Yeah, we can see. Can go ahead.
Okay. Thank you, Dr. Vinith, and thank you, Yashoda Hospitals, for the opportunity. So let's begin with the topic, pediatric trauma or the trauma in pediatrics. So we have a lot emphasis has been given on trauma and the golden hour protocol, management of trauma in the first hour. So let's talk about what actually happens in the pediatric trauma. So let's begin with a few of the facts about pediatric epidemiology. That is, it is a leading cause of death above the age of 4 years in adolescent, and approximately 25% of traumatic injuries occurs in children. Other most common causes of injury-related death in pediatrics is because of the traumatic brain injury. It can be because of the motor vehicle crashes, because of the homicides and the suicides, mostly in teenage age group. This is the data which has been taken from US, because in India we don't have much data available, and it is the older data which says that approximately 700,000 injury-related deaths happen worldwide in less than 15 years of age group, and almost 14,000 deaths happened in 2016 itself. And as compared to adult, we have seen both bimodal distribution in injury death rate in both children and teens. Why the teens are at increased risk is because they are more exposed to the hazards. They are more exposed, and they do take risk more. And infants are more exposed because of the high risk of inflicted trauma and the non-accidental injuries. Coming on to the differences in pediatric versus adult anatomy and physiology. So we have all learned about adults. We know about adults much, and we know about the ATLS protocols. When we talk about pediatrics or the pediatric age group, there are anatomical and physiological differences. Like when we compare head and the brain, there is larger surface area of pediatric patient. The cranium is thinner. There are open suture line. There is large extraaxial intracranial space, and the head is larger, more so. The consideration why is this, because of this large surface area, because of this thinner cranium, is because there can be a significant bleeding which can happen because of lacerations or hematomas. They are more predisposed for skull fractures. They can accommodate a greater ICP increase. So it amounts to a delay in recognition of serious intracranial injury. They are more prone for shear and extraction, de-extraction forces. Coming on to the cervical spine, the differences like the facets is more horizontal, and the ligaments and muscles are more lax. So what it leads to is a higher level cervical spine injury and sure, that is the cervical spine injury without any damage. The airway, there is, the laryngeal cartilages are more pliable. The airway is smaller, and neck is smaller, and the neck is not so accessible. So in airway, they are less prone to fracture than adults, but there is more risk of soft tissue swelling and bleeding, compromising the airway. When we talk about the chest, or when we talk about the bone per se, the chest is more pliable. The chest wall is more compliant, it's pliable. Heart is more anterior, and mediastinum is more mobile. So they are more susceptible to barotrauma and there would be a minimal wall injury, but the organ injury will be more serious. Similarly, in abdomen, there is it's relatively larger size abdominal organs are there. The thick visceral capsule is there, and the abdominal fat or the elastic ligament attachment is less. So they are more predisposed for blunt abdominal trauma, and this can limit hemoperitorium and ultrasound sensitivity. Skeleton, as I already told, because of the incomplete calcification, bones are more pliable, and there are specific fractures like green stick fracture, which is unique to children. Body surface area is higher, and there are thinner skin there, so they are more predisposed for losing the temperature and going into hyperthermia. The vital sign, that is the BP, heart rate, respiratory rate, saturation, they are more variable, which vary according to the age. When we talk about the ventilator settings or the ventilation, the tidal volume x-rays, there is smaller FRC. Uh, Whenever we deal with a trauma patient, the protocol is same. The ATLS guidelines is same. Like you have to go through a primary and secondary survey. So just a quick review of the ATLS primary and secondary survey. So in primary survey, what are we going to do is we do a quick initial patient assessment, which identify the life-threatening injuries, and the ongoing active resuscitation happens on. In secondary survey, we do a head-to-toe examination, and it's a more detailed assessment of injuries. So every one of us know about the primary survey, which is your ABCDs E, and every trauma patient should arrive boarded on board, and the C-span should be immobilized. The smaller size collars are available for school age and adolescent, and if it's an infant or toddler, then you have to fix the cervical spine and immobilize the cervical spine with rods and tapes. As we say, as soon as the patient reaches the emergency, take the vitals, go as per the ABCDEs, and A is your again air vent, cervical spine precaution, B is your breathing ventilation, C is circulation and hemorrhage control, D is disability, and E exposure and environmental control. Coming on to airway and cervical spine protection, the few changes which are there is definitely you have to check for the airway patency and clear secretions. In children or in infant, we have a larger occiput, which will result into a passive extension of cervical spine, and it causes a distortion of airway anatomy. So what you need to do, you have to maintain a neutral spine position rather than a jaw thrust kind of thing, which you do in the adult. If the kid is already intubated, definitely confirm the endotracheal tube placement via first the clinical confirmation by auscultating the lungs for equal air entry. Take a look with laryngoscope. Do a entitled CO2 if you have available oxygen saturation and X-rays, and ensure the adequate cervical spine protection is ongoing. Breathing part, again, check for adequacy of breathing, see the effort, see the breath sound, see the oxygenation which is there. Assess if there is any need for intubation because of the breathing compromise. Assess for pneumothorax and look for the tension pneumothorax. Again, in ATLS 10th edition update, what happened was we changed for adults, the needle thoracostomy was changed from second intercostal space mid-clavicle line to to anterior axillary line, and the ICD insertion was changed. But for a pediatric patient, the needle thoracostomy is still second intercostal space mid-clavicle line, and if you have to go ahead with the ICD insertion, it's fourth intercostal space, just anterior to the anterior axillary line. Circulation part, the pediatric patient, they're more predisposed for having hypovolemia. It's the most common cause of shock in pediatrics, hypovolemia. Definitely, two large bore IVs needs to be inserted, cross match type, and screening needs to be ordered. If you're thinking about the fluid resuscitation, it's always a crystallite bolus, and it's 20 ml per kg rather than 30 ml per kg, which is given in adults. And if the bolus with one bolus or the two boluses, the BP is not improving or the condition heart rate is not settling down, Early transition to a blood product of PRBC, 10 to 20 ml per kg has to be considered if the child weight is less than 40 kg. And definitely look for the obvious and non-obvious sources of bleeding in scalp. Now, in adults, we have this concept of permissive hypotension, but in children, in pediatrics, it's not recommended because hypotension is definitely a late finding of shock. In massive transfusion protocol, if you are going to transfuse more than 40 ml per kg of blood, or the half of the blood volume has to be replaced in 24 hours, then this massive transfusion protocol needs to be in place. The role of or the evidence of tranexa or tranexamic acid in pediatric is not there's not much evidence of it, but if the kid is of higher age group above 12 years, then within 3 hours of injury, tranexamic acid needs to be given. Disability, you have to again assess the mental status. There is a modified pediatric GCS which I'll be talking about, which is it deviates a little than the standard adult GCS. And then your quick assessment of disabilities by APPU, that is your alert on verbal response, on pain stimuli, or unresponsive. Definitely look into the pupillary response. Is the pupils reacting? Is it equal, or there is a either the pupils are sluggish or there is anisocoria. Look for any focal neurological deficit. Look for RPS, and also think about proper analgesic and sedative because pain is often untreated in a child. This is the Glasgow Coma Scale, which depicts it's the adult Glasgow Coma Scale, and the next one is your pediatric GCS, where there have been changes in the verbal response, how to assess for the verbal response of a child, and how to assess for a motor response. So eye opening remains the same. It's the scoring is also the same, and the criteria which you are looking is same. That is spontaneous eye opening, you give a score of 4, to sound you give 3, to pain 2, and none is 1. But in verbal response, if the kid is smiling or the infant is smiling, is oriented to sound, interacts or follows the object, then the score is given as 5. If the kid is crying, it's irritable, the score is 4. If the kid is only crying to pain, it's a score of 3 is given. And if the kid is only moaning to pain, a score of 2. And if there is no response, it's none. Motor response remains the same as depicted. Now, exposure and environmental control, again, you have to assess all surface area, do a log roll, see for any spinal deformity, note any step deformity is present, and if there is any pain, or if the kid cries while you are, checking the spine. Also, look for any vaginal or urethral bleeding. Prevent hypothermia, keep your emergency warm or the trauma room warm, use blankets and warmer for the infants. Now, our primary survey goals remains the same. Like for airway, if there is inadequate airway, you are going to secure and protect, and make sure the trauma team or the person who is the senior most person who is available on the team, or the anesthetist, emergency physician, they go with the airway, securing the airway in pediatrics, because definitely there are changes, and there is a change in technique when you are going for the intubation. For breathing assessment, if the child is apneic or bradypneic, then you have to go ahead with at least ambu bag ventilation, do a positive pressure ventilation until you intubate the child. Hypoxia, definitely supplemental oxygen needs to be started. Tension pneumothorax, you again, the treatment is needle decompression and then followed by chest tube. Massive pneumothorax, the criteria is same. You have to go for the chest tube, and the involvement of cardiothoracic surgeon and a pediatric surgeon has to be taken in immediately. Open pneumothorax, occlusive draining, and chest tube. The goals of our circulation is prevent hypovolemic shock, give fluid bolus, give blood products, pericardial tamponade, though it's not that prevalent, or not the incidence is not so much in child, but again if it's there, give a fluid bolus, pericardiocentesis, and a thoracotomy. If the kid goes into cardiac arrest, the chest compression needs to be started, and thoracotomy, the ED thoracotomy is only for the penetrating trauma, not for the any blunt abdomen or blunt chest injury. Disability, if you are suspecting a spinal cord injury or a spine injury, do a immobilization of the spine and prevent cerebral herniation by putting the child on ventilator, doing a hyperventilation, giving mannitol, the dose which I'll be talking about. Prevent hypothermia, give warm fluids, external warming, and if there is exsanguinating hemorrhage, apply a dial pressure. So these are all we have learned about these when we talked about trauma in adults. So the same principle applies to pediatric as well. Few tweaks here and there. Now, adjuncts to primary survey access, you have to see immediately as soon as the kid comes in or the patient comes in. Take a IV. If your 2 attempts of IV has failed, you have to go ahead for intraosseous line. Monitor should be attached, your cardiorespiratory and pulse oximetry should be there. The blood work which goes for a trauma patient is CBC, electrolyte, blood gas, creatinine, your PTINR, blood group cross matching, LFTs, lipase amylase. Beta HCG if the female is of reproductive age group, if there is a female child. Imaging, everything has to be either bedside or in a controlled environment like your x-rays, your pelvic x-ray, c-spine x-ray. Generally now we don't go ahead with the c-spine x-ray. What we prefer is we do a head ct if there is a neurological, we are suspecting a head injury, and along with that ct head, we also do a cervical spine screening so that is any minimal injury is also detected earlier. Role of e-fast, we all know, but the fast is limited to only 30% of solid organ injury because there is no demonstrable free fluid. So even if you are getting a negative fast on your first fast examination when the kid has come in, do a repeated fast examination if the condition is not improving, and go for a CT scan, see CT abdomen if the condition of the child allows permits. Now, there is one change in the rule, that is the criteria when we are looking for head CT, doing a head CT in pediatrics. So that is called as PECAN criteria, and it is divided into two parts where if it's a infant or younger than 2 years, whether you have to go ahead for CT's head or not. So if the kid had the kid is in altered mental status, or if the Jesus is less than 15, when on examination you're finding a palpable skull fracture, definitely go ahead for CT head. If none of these is present, and then you check whether there has been, LOC, that is loss of consciousness for more than 5 seconds, if there is any non-frontal hematoma, or if the kid is not acting or behaving normally as per the parents, because the parents can tell whether the kid is behaving in a normal way as whatever way he or she behaves at home, or there has been a severe mechanism. So if any of this is positive, observe recommended. So we generally go with a CT head just to have a baseline CT, what is there. Few of the institute of few of the pediatric surgeons or neurosurgeons, they go ahead with the observation because they don't want to expose the kid with radiation. But definitely having a first sense of injury and having a first sense of what is there in CT gives relief. If none of this is present, then there is no CT required. Now I'll talk about what is severe mechanism of injury. So if you can see in the pictorial description that if the kid has been thrown out of the car, or the injury has happened because of the motorized vehicle injury, or the car has overturned, whether the kid was wearing any helmet or not, if there has been fall from height of more than 3 feet, or any heavy object has fallen on the head. So these are the severe mechanisms where if any of this is present, you have to definitely go ahead and think about doing a CT scan. So this was the pecan criteria when the child is younger than 2 years. Similarly, we have a criteria when the child is 2 years or older. Then again, it's altered mental status if the GCS is less than 15, or there is sign of basilar skull fracture. Now, basilar skull fracture, we all know, if there is raccoon eye, if there is mastoid hemorrhage is there. So if any of these is present, definitely CT head is recommended. If none of these is present, was there any history of LOC? Is there any history of vomiting or severe headache is present, or any severe mechanism of injury is there? So in that situation, CT head and observation, you have to give it a try. Either you want to go ahead with observation, admit the patient in the head with observation, or do a CT head, the first line CT head. If none of this is present, then no CT is required. So this is the difference in adult and the pediatric CT head criteria. After this is done and all, after this is done and all of, it is- can you go? So after the primary survey is finished and the resuscitation is ongoing, we go ahead with the secondary survey, which is a head-to-toe examination, and we take a ample history. In ample, we check the allergies, we check the medication, what the medication was on, the patient was on. Was there any past medical history? When was the last meet? And what actually happened? Like what were the events surrounding the injury? Now, there's something called as trauma triage score, that is revised trauma scale. This is used in adults. So, quickly about what is revised trauma scores. So, it consists of three parameters. You take into account the GCS, you take into account the systolic blood pressures, and the respiratory rate. So higher the score, there is higher the chances of good outcome, and the lesser the chances of mortality and morbidity. So in revised trauma score, in GCS, if the GCS is between 15 to 13, you give a 4 point, and if it's between 12 to 9, you give a 3 point, 8 to 6 to 5 to 4 1, and if the GCS is 3 or less 3, then you give a point 0. Similarly, with systolic BP, if it's more than 89, you give 4 points. If it's 76 to 89, 3, 50 to 75, 2, 1 to 49, 1. And if the BP is not recordable, then you give a point 0. Similarly, respiratory rate 10 to 29, 4, more than 29. If the patient is severely tachycardic, you give 3 points. If its patient is bradypneic, 6 to 9, you give 2. If it's severe bradypnea, like the respiratory rate is falling below 5, you give a point of 1. And if there is respiratory arrest, you give a point of 0. So higher the RTS score, higher is the probability of a favorable outcome. So, in pediatrics, we have a pediatric trauma score, and it includes a more intense way of scoring, like the weight is included, the airway is there, the systolic blood pressure is there, the GCS or the level of consciousness is there, is there any fracture involved, or how is the cutaneous, how is the skin of the child. So, if the weight is more than 20 kg, then you give a score of +2. So each parameter is either scored +2, +1, or -1. So if the weight is more than 20, you give +2. If it's lies between 10 to 20 kg, you give a score of +1. Or if the child is less than 10 kg, you have to give a negative scoring of -1. If the airway is normal, you are giving a score of +2. If the patient is on oxygen, or oral or nasal airway is there, you have to give a score of +1. Or if the child is intubated, any cric has been done, or tracheostomy, then a negative scoring of -1 is given. Similarly, with systolic blood pressure, if the BP is normal, like the SBP is more than 90, there is good peripheral pulse, and perfusion is okay, you give a score of +2. When a patient is hypotensive, the BP is between 50 to 90, and only your carotids or femoral pulses are palpable, you give a +1. If your BP is less than 50, there is weak or no pulses, you give a negative scoring. Level of consciousness, what you are seeing is, if the child is awake, a good score +2. If the child is obtunded, or there is loss of consciousness, you give a score of +1. If the child is unresponsive or is in coma, you give -1. Fracture, if none seen or suspected, If it's a single fracture and it's a closed fracture, it's not open. -1 if there is, open or multiple fracture. Cutaneous is talking about if there is any skin deformity, if there is any abrasion or laceration. If nothing is there, it's a positive sign. It's a +2. And if there is, contusion, abrasion, laceration, but less than 7 centimeter, which is not going through the fascia, you give a +1. Now, if there is tissue loss, if there is wound, if there is gunshot, or if there is a stab wound going through the fascia, you give a negative scoring. So any pediatric trauma score more than 8 should have a 0% mortality. So this is the significance of measuring the pediatric trauma score. And all injured patient with less than 8 score should be triaged to an appropriate pediatric trauma center. So in India, we don't have this concept of trauma centers, or where we have not predefined, okay, this is a pediatric trauma center, this is the adult trauma center. So at least refer this patient, stabilize and refer these patients to a tertiary care or a quaternary care, where pediatric surgeons are available. Now, a little bit about the head trauma, chest trauma, and the abdominal trauma, because head trauma are the leading cause of death and disability in childhood, and the mortality rate is as high as 20 to 30%. Between 0 to 14 years of age, the traumatic brain injury, there are almost 400,000 visits per year to the emergency department, and out of these, only less than one above require neurosurgery. The causes could be in infancy, it could be non-accidental injury, it could be because of the falls, or it could be because of the abuse which the infant can get from either the caregivers. In childhood, it's generally because of the motor vehicle accidents, going pediatrician, hit by a scooter or hit by another vehicle, or fall from bike. But this is the age where the kids go out of the house, they explore, they go on road. In adolescent, again, it's motor vehicle accident, pediatrician, bike, sports, and violence. Now, when we talk about the gender predisposition, if the kid is less than 5, if the age group is less than 5, male and female predisposition is almost equal. But as the age goes above 5, the male child is more predisposed. Maybe it could be because the male child is more into cycling, or is more going trying some or the other thing. So I'm not talking about gender discrimination here, but then this is what the data says. Now, head trauma, this is the pictorial description what actually happens in a head trauma. So we see there's brain volume, there's arterial volume in a normal person. Then you have the venous volume and your CSF volume. So when the head injury happens and there is accumulation of blood inside, there is edema. So what happens? The brain is there, the arterial volume is there, the mass is there. I mean the blood is there, and then your venous and CSS, they are compressed. And as this is when there is compensation is happening, and the ICP is still normal. As soon as the ICP starts, or the brain start decompensating, there is increased ICP, and the volume of this extra mass, or the volume of this hemorrhage increases. The CSF and venous, they start to go out, and the brains start to get compressed. So here is the increase in ICP which happens. The silent symptoms which we get in increased ICP in children would be headache, seizures, changes in vital sign, that is, the Cushing triad, the systolic BP would increase, the pulse would decrease, and there is, altered respiratory pattern. Vomiting can happen, there would be changes in speech, changes in, sensorium. The patient would go into altered sensorium. The eyes, what the signs which you will get in eyes is papilledema, pupillary changes, and impaired eye movement. The patient will start, the Jesus will start to fall. Posturing can happen. It can be decelerate or decorticate. There could be flaccid posturing and decreased motor function. In infants, what you'll see is the bulging fontanelles and the cranial suture separation. Increase in head circumferences, but this generally doesn't happen in an acute setting, and there could be a high-pitched cry. Now, the medical management of raised ICP would be definitely what we follow in adult, that we are following in kids also. Position head and elevate the head end at least approximately 30 degree. Mannitol is recommended. 20% arbuminol. The dose is 0.5 to 1 gram per kg per dose. Seizure prophylaxis, phenytoin 20 mg per kg, or that is the levetiracetam 20 mg per kg. Again, more emphasis on preventing hypoxia and hypotension. Control the external hemorrhage, maintain the C-spine precaution, and early intubation using rapid sequence intubation to prevent complications. Definitive management depends on the lesion and examination. Early involvement of neurosurgery is recommended, and admission for observation and closely monitoring for deterioration is must. Consider need for IV mannitol early because for raised intracranial pressures. Coming on to the chest trauma, because the chest wall is more planned, compliant, there you will not find much of rib injuries or rib fracture, but there will be underlying cardiothoracic injuries, that is, cardiac injury, and the lung injuries would be there. It amounts to 5 to 12% of pediatric trauma, and it is the second most common cause of mortality in trauma, pediatric mortality. 5% mortality is for isolated chest injury, and the mortality jumps to 40% if it's associated with head and abdominal injury. The most common causes, as we already discussed, are the motor vehicle accidents, the pedestrian hit by another vehicle, and unrestrained passengers in cars, bicycle riders, and the falls from height. Now, pediatric thoracic trauma has a higher risk, as I told, because of the compliant chest wall, because of the increased mediastinal mobility, and so tension pneumothorax develops quicker in these patients. And children are more prone to hypoxia, and they have the less capability to compensate for hypovolemia. Now there are two types of thoracic trauma. There could be a blunt trauma, and there could be a penetrating trauma. The blunt trauma you get when there is a high energy trauma which affects the internal organ. There is extraction de-extraction mechanism affects mediastinal structure. The penetrating happens when the penetrating trauma, it disrupts the underlying structures, and if you have encounter with this penetrating chest trauma, please do not remove these penetrating objects in the ED itself. They should be immediately transferred. Take in an IV line, get all your casts done and everything, stabilize it, and immediately the patient should be transferred to OT, and where a cardiothoracic surgeon must be able to remove this penetrating object, because we don't know what structure it must have pierced. So this is a pictorial description of pneumothorax, where you can see the collapsed lung in a kid. Now, a little bit about tension pneumothorax. The tension pneumothorax, the clinical sign which you'll get is hypertension, distended jugular veins, shifted heart sound, hyperresonance, and trachea is not midline. But in kids who have very short neck, you'll not be able to see the jugular veins. You'll not be able to see. You will not be able to feel much of trachea and see whether it's shifted or not. So you have to rely on your fast. You have to rely on your clinical judgment. The treatment, the emergent treatment is your needle decompression, which is you have to get a large bore IV, get it inserted over second intercostal space, mid-lateral line. So this has not been changed in ATA's 10th update. And your chest tube placement should be in the fourth intercostal space anterior to axillary line, which is a definitive management for pneumothorax. Abdominal trauma, so this is the last part, abdominal trauma, and a severe abdominal injury can cause a rupture of the liver, rupture of the spleen or the kidneys, rupture of bladder, and rupture of gut or mesentery. Now, this is the third leading cause of traumatic death. It is often unrecognized in children because the kids they can't pinpoint where actually the pain is, and we have to be very vigilant about the clinical signs, and also because the ultrasound doesn't pick up early changes or the early hemoperitoneum in fast exhaustion kids. So you have to be very vigilant. You have to redo your fast or go ahead with the CCT abdomen. So the signs which you'll get is classical sign which we get in abdominal trauma is your seatbelt injury, your handlebar injury, and the sports related injury. So in seatbelt injury, you will have possibility of small bowel injury and chance fracture. In handlebar injury, or if the handle of a cycle or a handle of scooter has stuck on the abdomen, you might get a duodenal hematoma or pancreatic injury. And in sports-related injury, or kick by another kid, or a ball-related, the kid was playing cricket and the ball has hit the stomach, so you might get a laceration of spleen or kidney or bowel. So this is the pictorial description. This is a classical handlebar injury. This is the seat belt injury, which is shown here. Now, if the vitals are unstable, even after your fluid boluses, even after your blood transfusion, it gives you an indication that this patient should be, immediately transported to or with a pediatric surgeon and for exploratory laparoscopy. If you are not able to find any other, source of bleeding in your chest or pelvis, so the person or the kid has to be, transferred to the OT fast to look for any free fluid in the abdomen, and CT, that is the CCT abdomen, which is the gold standard for diagnosis. But this should be kept for the stable patient because it takes time, and definitive management is dependent on the specific organ injury. Traumatic arrest, a little bit about traumatic arrest because doing a ED thoracotomy, and let me tell you, I haven't seen one uh, yet in my 12 years of career. So emergency thoracotomy has no role in blood trauma. The key interventions would be for, if there is a traumatic arrest, uh, place a definitive airway, manage your major external bleeding. If there is cardiac tamponade, do a chest decompression and administer blood. Apart from whatever you are going ahead with doing CPR and all those things. So ED thoracotomy is only for the penetrating chest injury, and it should be done by a person who knows what he's doing, like a cardiothoracic surgeon. Now, in my conclusion, pediatric trauma and injury are mostly preventable conditions because if you are vigilant enough, if we monitor what the kid is doing when the kid is on road, is playing in the playground, or a kid is playing in the balcony of a house, so we would be able to prevent more than 50% of injuries which happen because of the fall from balcony or from slides or accident which happen. The principles of management is always it always includes a well primary and secondary survey. The ATLS guidelines needs to be followed, and you should be a little more keen to admit for observation and ask for help and consult your specialty services like your surgeons, your urologists, your general surgeons, your cardiothoracic surgeons, and neurosurgeons, of course. Earlier their involvement, there is more chances that we'll be able to diagnose hidden injuries and that will not get escalated. Little emphasis on trauma team because your trauma team must be in place. It always includes ED consultant, always includes the ICU consultant, the intensivist, and your general surgeon, your cardiothoracic surgeon, if you have in the hospital. So these 4 5 people they are a part of trauma team including your nursing team. So any trauma patient should get a multidisciplinary approach and the ATLS protocol must be followed. Thank you so much. So I'm open for questions.
Uh, Thanks a lot, Dr. Shefali. It was a good presentation. I'll just have a check if there are any queries. Guys, you can post your questions if you have any over here. Yeah, there are no questions as such. Guys, the forum is open for discussion. Any questions, please post over here. There is one question over here. They were asking about the
Yeah,
ICD
so
sites.
regarding ICD sites, yeah. So the 10th ATLS update, it has said earlier the size was 30 to 36 French for adults, and which has come down to 24 to 28 French size for the adults. In pediatric, the size is more reduced depending on it's almost 20 French, approx 20 to 24 French size of ICD for pediatric. But if you're dealing with infants, then the size goes down as more.
Yeah, any more questions further? Uh, Fine, there are no questions more, I guess. Yeah, I think we can close the session. Thanks a lot for your time and your beautiful presentation.
Thank
Any
you,
further
Dr.
questions, guys, you can post over our site. We'll come back with the answers, get back with the answers. Thanks a lot, Dr. Shefali.
Thank you, Dr.
Thank you,
Vinith.
Yashoda Hospitals, for providing this education session. Thank you.
Thank you so much.
See you.